All right, good afternoon. Today I'd like to talk about new trends in anabolic steroids and image-enhancing drugs. As we're going to see, the users are changing, the drugs themselves are changing, the usage trends are changing, and I think it has a lot of important implications for harm reduction and of course the health of the user population. Now, when we first saw steroids being diverted for misuse, the profile of the average user was a serious athlete, a competitive athlete, a bodybuilder. These tended to be people that were very experienced with training beforehand, often would use or turn to anabolic steroids or other medications later on when they were near at their peak level of performance. So steroids were typically another tool in the athletic arsenal, you would say, for getting to a new level of achievement that they weren't able to reach beforehand. Now, as we'll see, the user demographics have changed dramatically in the last 50 years since we first started seeing the misuse of steroids. This, I think, is potentially one of the most important slides in the presentation. I probably should have saved it for the end, but for flow purposes, I think it works better in the beginning. This is a recent survey. It was just published last year of nearly 800 self-reported anabolic steroid users. It was very detailed. It was a 99-point questionnaire looking at various aspects of their use, their patterns, their health, and other potential issues. And the demographics of this population are, I think, quite remarkable in contrast to how steroids were originally being used. We have a mean age of 25 years right now. A very good portion of users are below that age. 70%, actually a little bit more than 70%, use steroids or exercise recreationally. They're not competitive athletes anymore. Some percentage, of course, is, but the vast majority now are just people that are using them for image enhancement or to improve, I guess, their performance in the gym or various recreational activities. Polypharmacy is very big now with steroid users. The average report here in this questionnaire was 11 different agents that are being used in the arsenal. Of course, not all at one time, but the steroid users today, and of course other image-enhancing drugs, are very versed with a broad population of different medications that they're using. Now, some other associations that may not have been as obvious or as easy to predict. First off, the steroid user today is twice as likely to fit the criteria for a substance abuse disorder. They're twice as likely to have used cocaine in the past year. We see they're twice as likely to report a history of sexual abuse, and anxiety disorder is more common in the steroid user population today. Now, of course, that's not to say there's a direct association between steroid use and any of those in terms of a cause-effect relationship, but we do know that this appears to be the demographic. The population of users today are at risk, but have other issues as well that are going to be much more common than you see in the general population and may need to be addressed in addition to the anabolic steroid use. Now, just some observations that I've seen, perhaps some of you have seen this as well. I'm noticing more young users of anabolic steroids. Again, typically where we started out, where it was older, more experienced athletes, a lot of the users now are younger. They haven't been as experienced with training. I see much more commonly now people using steroids and image-enhancing drugs because they want to get the results that they're looking for much faster, as opposed to using them to go beyond what they can achieve naturally. It's a shortcut to getting the results that they want. And I think more of the population of users is a bit less informed about the drugs. And that's not to say there are not many very well and deeply informed people that do use steroids and image-enhancing drugs, but I'm noticing more people that that they would, for instance, a measurement, a steroid dosage is measured in milligrams. Milliliter is a volume of measurement, and that's irrelevant to actual concentration. But you'll see more users that will talk about how many milliliters they're injecting, how many tablets they're taking, as opposed to how many milligrams of a particular substance they're using. So there seems to be a little bit less information about the dosages that are required. and exactly how they could be used to best effect and higher safety. Now, the practices of steroid users have changed too. Some of this is an evolution of the market of the drugs, steroid and image-enhancing drugs. Others may have to do with just changing trends, people getting together and sharing experiences. One of the first is the doses are getting higher. I'll give you an example. When I first started researching anabolic steroids and getting involved myself, a typical cycle for even a relatively experienced athlete or bodybuilder may have been 400 milligrams a week of an injectable, like testosterone or nandrolone or a mix. And then perhaps that would be combined with an oral steroid, maybe methandrostenolone or dianabol at a dose of maybe 20, 25 milligrams today. That was a formidable program of steroid use. And in many circles today, that kind of cycle it's almost laughed at among the community as too small or not significant enough. What I'm finding today is more people are going to baselines of use where they consider perhaps even a gram a week of testosterone or more as a good baseline to work with. And then they're stacking other injectables on top of that. They're stacking other orals on top of that. So without a doubt, I think that the usage has gone higher. Some of it I attribute to people getting together on the internet and talking about their experiences. And I've seen over the years this almost one-upsmanship where one person says, well, I've done 500 milligrams. And then people come forward, oh, I'm doing 6 or 8. And it just seems to have evolved where there's this mentality now that high-dose use is the more accepted way to use these drugs. And one important thing to understand about steroids is there's a very distinct dose-response relationship with these drugs, and it's not linear. In low doses, they're very ineffective for building muscle. In moderate doses, they're very effective for building muscle. As you get to higher doses, the return for the additional dosage increase tends to be very minor. And the higher you go in dosage, the less incremental the increase is in the gain. So it is generally most productive and certainly much safer for steroid users to use these drugs in a moderate dosage range as opposed to tacking on these high doses that seem to be much more popular today. Another thing we're seeing a bit more of is the practice of spot injections. As the video mentioned before, there's really only a couple of sites that are acceptable for an oil or water-based steroid solution. That's the upper outer quadrant of the glute, thigh, and in a last resort, the shoulder. You'll see more and more people that are using these drugs in all sorts of muscle groups, biceps, triceps, calves. Essentially, they're using these drugs to increase institute site-specific growth, for themselves. And anabolic steroids are largely systemic-acting drugs. They reach circulation, they circulate, they hang around the body for days, weeks, and so their effect is not really localized. In fact, most of the drugs, especially the oil-based injectables, they're inherently inactive until they reach circulation. There's an ester that prevents the steroid from doing anything. It reaches circulation, it breaks off, and then the hormone is free to act on the tissues. So the vast majority of these drugs are really completely inactive in local tissues, and a small portion of them may have moderate activity in a local tissue, but I think that's more than the risk that you face in terms of tissue damage, nerve damage is much more of an important concern, I think, than the, at best, modest increase that somebody might get from a spot injection. You're also going to see a lot more injections from steroid users and image-enhancing drug users today. Some of that is the practice of people taking more drugs and spreading out more injections. You're also going to see, as we'll get into shortly, there's been an explosion of this other class of non-steroidal anabolic drugs. Many of them were peptide compounds. Very often these drugs are injected every day, sometimes multiple times per day. So whereas in the past you may have a steroid user that typically injects themselves once per week, you frequently will find people that inject themselves several times per week or more, and again, on a daily or even multiple times per day. Now, there is a practice that has been gaining popularity, which is called PCT, or post-cycle therapy. Now, these are medications that anabolic steroid users take at the conclusion of their steroid programs to help their natural hormones get back in order. The thing you need to understand is, all anabolic steroids, they mimic the effect of testosterone in the body. Your brain quickly recognizes that you have too much testosterone, so it shuts off the production. This all comes from your testes. So they sit there inactive. They tend to desensitize to your own signals for testosterone release. So at the conclusion of a steroid cycle, there's this window where your natural hormone production is very low, and this causes a lot of problems. For one, it's a very strong environment for a loss of muscle mass. Your body's in a constant flux, taking protein in and out of muscle tissue. So when you have no testosterone at the conclusion of a cycle or very low, your other catabolic hormones are given much more activity. So on the one hand, there's a much more likelihood without proper PCT to lose the progress that was made on cycle. And also there's other psychological issues and other health issues as well. But in particular, you'll see often issues with like depression, sexual dysfunction. These are issues that are often linked to testosterone or low testosterone. So this is gaining popularity, PCT. This particular program is supported by many HRT physicians. This one was headed by Dr. Scally in the United States, who's very well known for addressing anabolic steroid-induced hypogonadism, which is something that is trying to become addressed in the medical community in the United States. It really isn't widely now. But a program like this is very effective for shortening the period in which there's low testosterone after a cycle. I understand it's not appropriate to recommend the additional use of drugs, which also carry some risk, but this is something that you will get questions about, and at least from my perspective, is something that needs a lot more investigation and perhaps a lot more use, I don't know. Now, the drug supply itself is also changing drastically. When we first saw anabolic steroids, they were exclusively pharmaceutical products. They were diverted from pharmacies and wholesalers and even manufacturers. But with the dramatic increase in demand, also with law enforcement attention, that's no longer the case. Pharmaceuticals do make it to the black market, but their availability is very low. It's probably 20% or less, and that's in UK, mainland Europe. In the United States, it's probably 10% or less. So actual trusted, sterile, pharmaceutical-grade products are very rare on the market nowadays. Instead, what people are faced with buying are a majority of products that come from counterfeiters or underground suppliers. Counterfeiters copy the legitimate steroid medicines. Of course, we don't know what's in them. The underground medicines are a fairly new phenomenon in terms of being a large-scale thing. This is the branding of illicit drugs. These are essentially labs that everybody recognizes, or most people recognize, as underground, not from real drug companies. And of course, there's a lot of risks with these kind of products. They're rarely, if ever, made under sterile conditions. Often they are sterile, but very often they're not as well. We see a lot of bacteria. I think in one series of tests, it was about 20% or so, had levels of bacteria that were absolutely unacceptable. Another trend with underground medicines, especially, is the use of multi-dose containers. It's much easier to take a 10, 30 or 50 milliliter vial. It can be sealed with a little hand device, a hand crimper. To do single-use ampules requires more equipment, more expense. So underground producers tend to use these multi-dose containers. Also with tablets, they don't do the push-throughs very commonly with one tablet or capsule. They just put them in a large bottle of 100 or 500 or so. And of course, multi-dose containers, they invite some other issues. We see, some of these are 50 milliliters. That's not uncommon. People will buy that because there's a discount. They get a good value for their money. It's often multiple cycles worth of steroids. So they may use it for 6 or 8 weeks, stop using it, leave it on the shelf, and go back to it a couple of months later. Oil-based steroids shouldn't breed bacteria quickly, but they should not be stored open for long periods of time either. I mean, 60 days is probably really the upper limit you want to use a product like that in a medical setting. And of course, multi-dose containers invite things like sharing among groups, where one person will buy the vial, they'll pull their money, and they'll all share it. And of course, as we know, that's a very dangerous practice. And if a needle is reused just once in that product, it could spread bloodborne virus to everybody that's using it. So, and there's also contamination today with these underground and counterfeit products. These underground suppliers can get access to the raw steroid powders that they need to make the products. The problem is almost all of this comes from this unregulated market in China. China is a country with an enormous manufacturing capacity. They do a lot of legitimate pharmaceuticals there. But they have this huge network of chemical companies, companies that make dyes, fertilizers, pesticides, things like that. That don't need to be manufactured to the same standards. They don't need distilled water and glass-lined containers and to worry about heavy metals and things like that. So we're seeing these raw powders come out with contamination. Sometimes different drugs are in there, perhaps other things that they were producing on the machinery. Again, heavy metal contamination has come in quite a bit. So there's a real concern that the products that are being used, even though they carry the steroids that people are looking for, they very often carry other things in there. And many times, too, these contamination levels are fairly low. I'm not going to say that that's the case every time at all, of course, but that does present one bit of a problem in that the users aren't going to recognize the problem. They'll be using these products, they may have heavy metal buildup in their body, or maybe being affected by other medications that they just can't quite pick up on it. It's pretty fast to get the word out that a particular lab is making very unsterile product with a lot of bacteria. Those infections come on quickly and people can spread the word, but this contamination goes unnoticed, and we really aren't going to know the long-term health implications of some of this, and may never know because it's so difficult to monitor. Now, going on the higher dose trends, there's also this underground arms race that's happening with these labs. Now, when you're an underground lab, you don't have to answer to anybody but your customers. There's no regulation to look after. There's nobody telling you what drugs are approved or unapproved, how much you should dose your products with. So on the one hand, the labs themselves are going for higher concentrations because the customers like it. They get more value. This here is a bottle of testosterone that contains 400 milligrams per milliliter. There's never been a pharmaceutical product that has carried anywhere near that dosage of steroid. Above it is a box of stanozolol. For people familiar with this drug, when it was widely available for human use many years ago, it was produced in a 2 milligram tablet. There were a small number of preparations that were produced in a 5 milligram tablet. That's a 50 milligram tablet. That's a very high dose of stanozolol. One tablet, from my perspective, is too much to use. There are people out there, and you will see them, I'm sure, that will be using products like this that are using 2, 3, and 4 tablets a day. Some people have the mentality that they have a bit of information that you take Winstrol or D-Bol 5 tablets a day. When it's a 5 milligram tablet, that's 25 milligrams. You can see the dosage here. It's dramatically different if this is the type of practice you're doing. And of course, the strain that's going to go on with your liver and cardiovascular system with how it manages cholesterol and other risks is going to be amplified. Here's another example that I think is a bit troubling when you're looking at the shift in underground medicines. This product here, Oral Tren, it's methyltrianolone. Now, it's probably not very familiar to many of you because it's been off the market for a very, very long time. Methyltrianolone is the most liver-toxic oral anabolic steroid that's ever been tested in humans. Very quickly, they realized it was raising liver enzymes very dramatically in patients, often in doses below 1 milligram per day. It's a very, very powerful steroid. Works very effectively for building muscle, but it has a lot of inherent risk to it as well. This is back now. Methyltrianolone is gaining in popularity. There's another version, dimethyltrianolone, which is significantly even more potent, has never been tested in humans. You're going to find more and more of this as well as the years go on. What's happening is these producers are looking through the old research books. With anabolic steroids, there was maybe a couple of dozen compounds that reached clinical usage. There was hundreds, if not 1,000 or more, that were studied, assayed for potency in animals, and just abandoned for one reason or another. Some may have been too toxic, other ones just, there's no financial viability for 500 different steroids. So there's this large volume of information out there that they can go to, find really potent anabolic steroids that were never marketed and bring them to market. There's also this explosion again in new drugs that are being used for image enhancement and performance enhancement. One of the first classes that I think we're going to see a lot more popularity from in the near future are these SARMs, these selective androgen receptor modulators. These are drugs that mimic the effect of testosterone at the testosterone receptor in muscle and in some other tissues depending on the compound. So they mimic the effect of testosterone in one area of the body, but they tend to not mimic the effect in another. Generally, the clinical application for these drugs is they want to develop compounds that increase muscle tissue for medical purposes, but don't stimulate the prostate. These drugs hold a lot of promise, I believe, for hormone therapy and stuff, as we'll get into in a minute. But they're also very new. S4, which is the first one that seemed to hit the black market, seem to work, but also have some side effects, particularly with vision and what have you. It's not as widely used today. Osterine is the new one. It's in clinical trials right now. The safety data on it appears pretty good so far, but again, we're only in, I believe, phase 2 trials of this, so it's still a little bit early to tell. This drug is also already in wide use on the black market and is available through purchase over the internet and what have you. I'm not going to go into all of these different compounds as well, but growth hormone releasing peptides is another area that we're seeing a big explosion. All of these medicines, what they do, when taken, they stimulate the body to produce more of its own natural growth hormone. Barring a couple of the first ones, these fragments, they copy the effect of growth hormone, but in certain regards. These fragments tend to be much more potent for fat loss. But again, this group is largely working on your natural hormone production of growth hormone, which is an anabolic hormone. This is not as effective of a practice as using anabolic steroids, but it is widely being accepted as a complement to the practice. Also, the IGF-1 family is growing in prominence. IGF-1 is the main anabolic product of growth hormone. When you administer growth hormone, your body releases more IGF-1. IGF-1 is the compound that actually acts on the tissues to increase anabolism. So we're seeing more of that. Recombinant IGF-1, which is just a copied version of your natural IGF-1. Long R3 is also very popular on the black market. That's a synthetic form of IGF-1, has not been studied in humans. I believe at this point they've actually abandoned this as a medicine. I don't think it's being pursued anymore. And there's some other drugs in the area as well. Mechanogrowth factors is an IGF-1 splice variant in the body that's also anabolic. And then there's some other new compounds as well. Thymosin beta is a regenerative protein that seems to be getting some use. The prostaglandin family, prostaglandin F2 alpha, this is an analog of this, is also a potent muscle-building hormone. This one tends to be a bit problematic in terms of side effects, particularly gastrointestinal, so something to keep an eye on. And also tanning agents are gaining in popularity. The first one that seemed to be really hitting the market hard was melanotan. Now we have melanotan 2. And also a new PT141, which is another new derivative. These are all given by injection as well. We're also seeing huge increase in infections. Some of this is probably due to the shift towards underground products. Some of it's probably also due to poor injection technique and the less experienced users or people that are coming into the practice with less information. Abscess when it's an infection. Also, sterile abscess is something that we're seeing more of. That's not due to bacteria, that's due to poor assembly of the product. Either the components are too caustic, maybe the pH is off in the solution. There's other minor things that could be affecting in there, and that's typically causes tissue damage, nerve damage, some things like that. So, syringe filtration is gaining in popularity. Now, this is a difficult thing to address because there's risks and benefits to this practice. A proper syringe filter, 0.2, 0.1 micron, can remove all bacteria from a solution. If there is a product that that has bacteria in it. This could certainly clear it, provided that it was used properly and none of the solution contacted any of the final product that was being filtered. But there's a lot of limitations to syringe filtration too. For one, the pyrogens that bacteria produce and release will get into this final solution. So you could still get a fever even though, and have reaction even though there's no more bacteria in the product itself. And often there's a false sense of security with syringe filtration. Syringe filters cannot remove much else other than bacteria, which is a big organism. They can't remove other drugs, contaminants, heavy metals. These will all pass through the filter because they're much smaller than the holes in the membrane. So, again, on one hand, there may be some potential benefit to it, but there's also the risk. When you use syringe filtration, there's added handling of the solution. It's typically done on an entire vial basis because there's some loss of solution in the syringe filter itself often. So what happens is the person will take a new vial from an underground lab, be a little concerned about potentially what's in it. We'll take the entire contents, filter it through this syringe filter, and put it in a new sterile vial. Now that's great in practice, but of course, as we all know, the handling of injection equipment needs to be done very carefully. So if at any point in time that the person touches it or in the wrong spot, or can actually inadvertently introduce bacteria to the product when there may not have been bacteria in the first place. So this is something I think that definitely needs a lot more investigation in terms of a harm risk standpoint. Hormone replacement therapy. This is something I am proud to say that the United States, I think, is leading in. I expect this is going to be much bigger medicine throughout the UK, mainland Europe, in the years to come. What this is the recognition that men, typically over the age of 35 or so, actually we begin losing our testosterone at the age of 30, our hormone levels decline. For many years, we thought that this was possibly a good thing. Doctors often attributed the lower age of heart disease in men to testosterone. What we're finding now is that the decline in testosterone is actually a big health problem. It increases cardiovascular disease risk, diabetes risk, metabolic syndrome, even cancer risk, and some other health issues as well linked to testosterone. I bring this up because I believe that there is going to be a portion of people that come into needle exchange that are using anabolic steroids on the black market that truly have a medical need for testosterone and will be much better served with physician oversight and a physician's prescription, having the blood work monitored and their hormone levels replaced to the normal physiological levels for a young person. Again, the data looking at the health benefits of this at this point is overwhelming. Testosterone is becoming big business in the United States. You can't watch TV for more than a couple hours without seeing commercials being advertised for different medicines that contain testosterone. And in the last, I believe, year and a half, we had 4 different new medicines introduced. So the drug companies are really, really hot on this subject. The science is really solid and sound. And there does validly seem to be a health need for testosterone. So again, I think this is just cause to rewind a little bit and remember that these are medications. Anabolic steroids do serve clinical purposes. And certainly with testosterone, this is a growing and increasingly recognized as valid use. So it would be great if in the years to come, a percentage of the people that come in using black market drugs could actually be recommended to a physician and handled with the proper medical care that they require. So what this is all getting to is really the need for needle exchange. On the one hand, injection equipment. Of course, with the increase in injections, look, injection is a high-risk practice to begin with, especially when done outside a medical setting by somebody that's properly educated on it. Everybody that's injecting, whatever they're injecting, needs new, clean medical equipment. But it's much more than that, I believe, now for the steroid and image-enhancing drug users. They need access to healthcare workers. They need access to good information, access to counseling. As I remember from the beginning, there's some other issues that's going on in this population that for many people should be and can be addressed. And perhaps that this will be an interaction point where the population is gaining the equipment that they need to do injections safer, but also having access to the counseling and the support services that they really need. And I want to leave you all with a word of advice. You do not have to be an anabolic steroid expert to help this population of patients. You're going to find that a good percentage of the people that come in are very versed with the drugs that they're using. They know the compounds. Again, not everybody. You don't need to fake it with these people. If you don't understand anabolic steroids, you don't need to be up on the dosages of every compound, what's stacked together and what's popular. You just need to be experts in harm reduction. You need to be experts in helping these people make their injections safer, and of course, getting them the secondary counseling that they may need for other issues. And again, polydrug use and other stuff is more prominent in this population. So it's great if there's people on staff that really get these drugs. People will relate to them. But I think from my perspective, you're much better off just relating to them on the level that you deeply understand, as opposed to trying to get into the world of anabolic steroid, the nitty-gritty in terms of the compounds and drugs if you don't have the time to really get into them. So that's my presentation for today, and I'm open to any and all questions.